Sickle cell disease in pregnancy. One of the most important things to remember here really is if the client is positive for sickle cell trait, you need to screen the father to make sure the father doesn't have the trait, because the chances of the baby acquiring sickle cell disease is about 25%. If the mother only has a trait and the father doesn't have the trait, then the baby has a 50% chance of having the trait. So the things that you worry about for a client who has sickle cell trait, because a client who has sickle cell disease, you will not be taken care of. A client who has sickle cell disease is going to be at risk for preeclampsia, preterm labor, stillbirth. A client that you might take care of who has sickle cell trait is at risk for having asymptomatic bacteriuria. So you must screen frequently for urinary tract infection. You also should screen for anemia. More than likely they will be iron deficient, anemic. Anemic. All right, so that's it for sickle cell. So one of the things to remember about thrombocytopenia, which happens quite often in pregnancy, I'm hoping you guys know what thrombocytopenia means, at least from medical terminology. It means low platelet count, usually less than 150. Some midwives are really comfortable managing clients that are anywhere between 80 and 90. Okay, classic textbook is, something between 100 and 150. You'll probably be okay. And of course, this is not indicative of fetal thrombocytopenia. So the screening test, of course, is a platelet count. So thrombocytopenia is low platelet count. And the screening test is a CBC. A lot of pregnant women have low platelets. And a low platelet, severely low platelet, is associated with HELLP syndrome. I know someone mentioned that before, HELLP syndrome, but that is associated with preeclampsia, and we'll get into that when we talk about hypertensive disorders and preeclampsia. Okay, so deep vein thrombosis, also known as venous thromboembolism or pulmonary embolism or thrombophilias. So as we know, the risk factors are pregnancy because of the hormonal changes, and screening for it is really through history. If someone tells you that they have had a pregnancy with DVT or a PE, of course, that's probably going to be somebody that you're going to refer. But you need to do your prenatal screening test around the hemoglobinopathies, just to make sure you don't have someone who has, I want to say, a 5-factor Lutein deficiency. You're not going to accept that type of a client. Factor 5 Lutein, rather, that person is at risk from cardiovascular, diabetes, and just clotting disorders, and you will not take that client. So one of the important things is to know the signs and symptoms. The client is going to come and say, I have pain in my leg. And it might be redness or swelling in that area. You're going to refer that client immediately. You're not going to try and diagnose it, ordering Dopplers. No, you're not going to do that. You're not going to give anticoagulation therapy. No, you're going to refer them out. But of course, screening is important. Is there a genetic factor? Is there family history? And also know the provoked and unprovoked. And read that in your book. Barney will tell you what provoked is, which is kind of surgery or some kind of fracture. And so really understand what that is. Glucose 6-phosphate dehydrogenase deficiency, also known as G6PD deficiency. This is part of the newborn screening test that's done. It is an enzyme that is produced for stability of the red blood cell. And so when it's low or deficient, you'll have fragile red blood cells. and certain foods trigger symptoms or trigger more fragility of the red blood cells. So foods like fava beans and anti-malarial medications or surgery in some infections. So these women, people are anemic. I believe the G6PD test can be done anytime. I believe you can choose that on a regular lab requisition. Usually pregnant women don't have any symptoms, but I have seen symptoms when, personally, I've seen symptoms in someone who had G6PD, unbeknown to them when they received anti-malarial pills. So management is avoidance of the triggers. All right. So a little bit about alpha thalassemia and beta thalassemia, both of which you probably will not manage. That is a condition where there is a deficiency either in the alpha or the beta chain of the hemoglobin. Sounds confusing, but just remember that is where the protein is carried. So the screening test is a hemoglobin electrophoresis, and just remember that the beta thalassemia major is the severest type, right? It's called Cooley's anemia, and the mother is at risk for cardiovascular diabetes, and that person wouldn't be managed by you. And these are microcytic anemia conditions. So I just want to mention that. And anytime this diagnosis is made, you will not take care of them because the baby's at risk for Bart's syndrome, hydrops fetalis. It's just not a client that you would serve. It's not a low-risk client. She needs care with a hematologist, IV iron, obstetrician, etc. So anyway, moving forward, we're just giving you just an overall understanding of alpha and beta thalassemia. Just know that they're microcytic anemias, and also know that it is a condition where the alpha or the beta chain of the hemoglobin is missing. And if that's missing, you know you have low oxygenation because you need a fully functional hemoglobin to carry the oxygen. All right.